welcome, and we would like to welcome Dr. LaVeist to this special series. The field of health disparity is an evolving one, and is in a sense is one that is taking a lot of growth in the last 10 years. And I think all the anticipation is that is one of the fields that is uniting many disciplines to address, to really have the connection between research and lifestyle changes in life and people to really bring community together. Dr. LaVeist is the William and Nancy F. Richardson Professor of Health Policy at Johns Hopkins, and he's director of the Center for Health Disparities Solutions at Johns Hopkins Bloomberg School of Public Health. Then he directed the Center of Excellence. He received his bachelor's degree from the University of Maryland, Eastern Shore, and his doctorate degree in medical sociology from the University of Michigan, and postdoctoral fellowship in public health at the Michigan School of Public Health. Dr. LaVeist has published more than 100 articles in the areas of sociology and health disparities. He's very well renowned in this area. And part of the reason I think he's fit very well with what we are doing here is because he has published extensively and is a consultant to many organizations how to use research, how to use biomedical research to really increase health outcomes in the context of clinical enterprises and that bridge between the sciences and addressing health. That's the passion of myself and other people here at Loma Linda. Then Dr. LaVeist has received many honors. One of the honors that he received that is very valuable for many of us is he received the Innovative Award from NIH, actually for his expertise in putting together area of sociology and health disparities and its implication to health disparities. He has written many articles, books. He's an author of the health disparities textbook, actually, that is used nationwide, including in the School of Public Health here. And then he's very well sought to have feedback in this area. Today is what we asked Dr. LaVeist to talk about, to guide us through the health disparities issues and to step-by-step current issues addressing health disparities in research. Then he's going to be, in this specific noon lecture, very data-driven from his own research and putting research from other also main groups nationwide. Tonight, he's going to have the keynote. He's part of the Institute of Medicine, and he is working in all these reports about health disparities, unequal treatment, how it affects our nation. And if you have some question for him, he's going to be available tonight and also today. Dr. LaVeist is a friend. We have been collaborating for many years, and he's an advisor of our center too. Thank you, Dr. LaVeist, for coming.
Thank you. And is this microphone on? Hello, can you hear me? Can you hear me? Can you hear me? Yeah, it's funny, speakers ask that all the time, can you hear me? So if you couldn't hear me, how would you know to say you can't hear me? People, it never seems to strike people. So I want to thank you. It's not on. Hello, 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 hello. Yeah, I hear that. Yeah, that's a little too loud now. Yeah. Okay. Dr. DeLeon, I want to thank you, or Marino as I call you, I want to thank you for the invitation. It's a pleasure to be here. And I'm really excited to be here because I'm speaking to the next generation of researchers. And, you know, I want you to know just how important you are, that this health disparities problem is, to my mind, the most important health problem that we face in this country. And finding the solution to this health disparities issue is, I think where the future of all health sciences really needs to be. So I'm unabashedly about that issue. How do we eliminate health disparities? And so I'm just so happy to see that we're going to be in such good hands with all of you. And the theme for what I want to talk about today actually goes right to that point, which is that health disparities is a very complicated issue to study. It's very complicated. It's not, if we could just do a nice simple study of cholesterol and the relationship between cholesterol and weight or something like that, that's all well and good. But there is so much complexity to this because the problem is biological, sociological, psychological, environmental health sciences. It's really all of these disciplines together that have to come together to really understand disease. And I'll tell you one quick story. I was in a faculty meeting once. I showed up early for a faculty meeting, so this was an unusual day for me to show up early, let alone on time for a faculty meeting. And I'm the first one there, and I'm sitting there in the room, and the second person to come, and this was at the cancer center. This was a meeting for the cancer center, and I was the first one there, and you just don't know how unusual that is, right? I'm sitting there by myself waiting. The second person that comes in is one of my colleagues who does work at the bench, the bench scientist. So she comes in and she's so excited and she has to talk to somebody about this new discovery she just had in her lab. And since I'm the only person there, she starts telling me all about it, right? And she's so animated and excited and talking about, she's taxing my knowledge of biology. She's talking about, and this protein does this. And then at the end of her sentence, she says, and then the gene switches on, and then the cell begins to hypermethylate, and then we have cancer. And she looked at me like I was supposed to go, wow. And instead I said, why did the gene switch on? And she says, the gene switched on. And then when it switched on, all these great things happened. I said, but why did the gene switch on? I mean, see, so to my thinking, it was, well, hell, if we could just figure out how to make that gene not switch on or switch it back off, then who cares about what happens, right? But for her, the exciting stuff happens once the gene switches on. And after, a little while of us going back and forth of me not quite getting why she found this exciting and her not quite getting why I didn't find it exciting, it occurred to me that we were both wrong. We were both wrong. If we're going to really understand cancer, we need to understand what made the gene switch on, and we need to understand what happens once that gene switches on. And we were both thinking in this very narrow, limited way of thinking. And I think the future of health disparities research, the future of health research is in understanding both what makes that gene switch on and what happens once it switches on. Because if we're going to find a way to stop cancer, the solution might come on either side of that gene doing what it's doing. You follow what I'm saying? Okay, so you're going to have to give me more feedback than this, or this is not going to work. So what I want to do with the time that I have with you today is that I'm going to manage this the way I manage my classes. I'm not going to stand here and lecture at you. I want to have a dialogue, a conversation, all right? And I'm going to talk about some problems and some challenges that we face in doing good quality research in health disparities. And I'm going to go through five problems that we encounter. And I think that we all, in various ways, regardless of what your discipline is, encounter these problems. And instead of waiting until the end, is now okay. All right. So what was I saying? This is your first test. What was I talking about? No. Okay, I was saying we're family, right? So we're gonna this slide here. This slide I think summarizes the health disparities problem, right? So I'm not gonna walk you through all the slides. This is the bottom line. We have this huge disparity based on race and ethnicity. We have a disparity based on socioeconomic status, and we have a disparity based on gender. If you notice, the guys are doing badly no matter what, right? No matter what racial ethnic group, right? You notice that? So is there a center of women's health here at Loma Linda? No? Yeah. Well, we have centers of women's health everywhere. Not many centers of men's health, right? But if anybody needs a center, I think it's the guys. But this is the chart that is the bottom line. But what this chart does is it begs a question that I think we don't ask often enough. And that question is, what is race? What is race? It is a fundamental question if we're going to do this research. What is race? Now, I don't know if you all have talked much about that this summer, have you? Okay, I'm going to start randomly picking on people based on what they're wearing, like blue shirt here. What is race? Like the human race. Yeah. Yes. Right. But it's the, so like most of you, I was going through life not having really thought much about this topic. What is race? What does that mean? And I had a postdoc who came to work with me. She was from Uganda. And she would often come to my office and ask questions like, you know, how do I get downtown? And I'd say, okay, you take the bus, and the bus you take, get a transfer. And I could easily solve those problems. But one day she came to my office and she asked me a question. She said, I'm taking an epidemiology class that you told me to take. I said, okay. And she said, every time they show health statistics for the United States, they always show it by race, like this chart. You notice that? So why do you do that? They don't ever just say, well, the cancer mortality rate is this. They always say the black rate is this, and the white rate is that, and the Latino rate is that, and so on. Why do you do that? What is race? We don't do that in Uganda. We didn't do it in the UK where she studied. But in the US, you always do it this way. What is race? And she thought that I would have a simple answer, right? You take the number 2 bus, and then you get the transfer, and then you down, right? And it set me off thinking about this topic and doing some research and actually doing some writing on, well, what does race mean anyway? And until we figure that out, how do we solve the problem of health disparities? So I'm going to show you a little bit of what I figured out or found when I started trying to figure this out. So this is a chart here that I put together. This is only a small segment of the protocol that the National Center for Health Statistics had for assigning race codes on birth certificates, right? The protocol is a lot more complicated than this. I just picked out 3 groups just to illustrate how it works. And what this chart does is the race of the father determines the race of the child, right? So if you have a Japanese father, white mother, the child should be designated as Japanese. Black father, Japanese mother, the child is black, right? That's what the protocol was doing. Except there were 2 exceptions to that rule. One exception is not on this chart, which is Hawaiian. So if either parent is Hawaiian, the child should be designated as Hawaiian. And the other exception was white. The only way that the child is designated as white is if both parents are white. So Hawaiian blood overrules everything else, and white blood is overruled by everything else. Now, can one of you tell me the science behind that? Is it something to do with ABO blood groups, or what is the science that would justify that? Right? This is purely a social and political decision that produces a statistic that we depend on a lot, right? Because we can't produce this chart without that data, and that data is influenced by political considerations, right? Now, what happens, this is the protocol until 1989. Now, what happened in 1989 is that NCHS issued a new protocol. This, by the way, is called the one-drop rule. So if you have 1 drop of non-white blood, you are whatever that 1 drop was. That was the official policy of the United States. Now, a friend of mine did a little study, informal study, where he called around obstetrics units where he knew people. This is how informal it was. But it was instructive and it was interesting because he found, and he asked them, how do you guys assign race codes in the real world? And what he found was that as many places as he called, he got as many different answers. So he called one hospital, they'd say, oh, well, I don't know, we look at the medical records and whatever the mother said she was, we just check that out on the box. Other places said, well, we look at the baby and we check a box. Other places say, well, we give the form to the parents and they fill it out and whatever they write, that's what we send in. And these are the statistics that we rely on. And this is how it's being collected. And there was a study that the CDC did of funeral directors, asking them, how did they determine race codes for death certificates? And what they said is, well, they look at the body, or they look at the family that comes to visit the deceased. I mean, it was that random, Scary, isn't it, right? And these are the data that we are relying on. So in 1989, the NCHS changes its protocol. So now the protocol says the race of the mother determines race of child, right? Regardless of what their combination is. Now, Japan, this was the protocol in Japan until 1985. Now, in Japan, the way they did it was that if your father was Japanese, the child was Japanese. Didn't matter what the mother was, right? But what was happening in 1985 is that Japan's population was dropping because the fertility rate was dropping. They weren't having babies. And one of its primary natural resources is its people. So this is a bad thing for the economy. They needed more Japanese. So what they did was they simply changed the policy so that if either parent was Japanese, then you're Japanese. And if you were born before 1985 and you happen to get caught up in this policy, you can apply to the government to have your race code changed on your birth certificate. Then there's Brazil. Now, Brazil made a whole science out of this here. So what Brazil decides to do is, what Brazil does is that if you have mixed parentage based on, race assignment, you go on to a third category, a category, by the way, that we used to use in this country, as you're going to see in a minute. And then within that category of mulatto, there are these finer distinctions made, and my Portuguese is pretty bad, so I won't try to read that to you, based on the relative proportions of parentage, right? So they made a whole science out of it. So the point here, all right, settle down. So the point is that you can have two parents, you can have a couple, right? And they can have a baby at one time, and then the next year have another child, and the two children would have different designations, right? Or you could have one baby, move to another country, and the same two parents have another baby, and they have a different designation. And what's going on here is that this concept of race is fundamentally a social and political construction. Now, that doesn't mean that race doesn't exist, which I sometimes hear people say. I wrote an essay. As a matter of fact, the paper that I've written, this might surprise you, that has been the most cited paper was an essay that I wrote one weekend because I got angry at something I saw in the research literature on race, where they were making claims about race there was just no science to support it. And I wrote this essay about what is race. And then people started citing that essay, and in their citation, they're saying, we shouldn't study race anymore. And then they would say, LaVeist, they would cite me. I'm like, oh my God, that is horrible, right? So that got me mad, and I wrote another essay. But more so than all the data-driven, all that stuff, the essays is what they cite. So I read another essay, but this time, because I figured they must not have read the article, the essay, for them to have said that I'm saying we shouldn't study race. And I wrote in the second essay, the title is my bottom line, which is why we should continue to study race, but do a better job. And that is the point, and that's what I want to alert you to. Some of the problems and even some of the prospects for studying race. So this concept of race in policy came into policy in the United States in 1977 with Directive 15. Directive 15 comes from the Office of Management and Budget. And what was happening was that there wasn't standardization across the states about how the data was being collected. So Directive 15 comes out and creates this standard. And what Directive 15 says is basically it says there are 5 categories that will make up race groups. And these are American Indian or Alaska Native, Asian or Pacific Islander, Black, Hispanic, and white. And Directive 15 defines these categories this way. So Native American means, or Alaskan Native means that your ancestry is from the indigenous peoples of North America. Asian Pacific Islander is India and China, right? Which these two countries alone comprise about 1/3 of the world population. And then if that's not bad enough, that we've subsumed all of that variation into one category, then we're gonna throw Koreans in there, and then we're gonna throw Filipinos in there, and then we're gonna throw in Vietnamese, and we're gonna throw in all the Pacific Islands in this one category, right, called Asian. Black is anyone who has origins from Africa, except North Africa or the Middle East, which is white. And Hispanic, and if all of these categories weren't problematic enough, then we have Hispanic, right? Hispanic means, now this is I don't forget what they wrote there. This is what Hispanic means. People who come from a country that was once colonized by Spain, except Spain itself, plus Brazil, right? Is that about right, what it really boils down to? So forget about the variation, cultural, genetic variation within those countries. So my mother's from the Dominican Republic, and she lived in Arizona for a while. Her biggest complaint when she was in Arizona was, I can't understand what kind of Spanish these people are speaking here. They talk too slow. They have different words, because of course Dominicans talk so fast that you can barely understand what, I do not understand what they're saying, and Cubans too, by the way. That's fast talking. But anyway, the food is different, but anyway, the bottom line is they get categorized into this one category, leaving apart that there's big cultural differences in terms of diet, in terms of music, in terms of even language and the way the language is used, different words that are used. Yeah, but I have my first question here.
What would you do when you categorize people into this Hispanic category? Are they taking also into account the fact that we have a lot of African descent? Like, I'm Afro-Latina. What's your ethnicity? What's your reason? Like, I'm Afro-Latina. My dad has African descendants, so does that make me Black? Because if I have an African descendant?
Yeah. Yeah, well, this is exactly, you're anticipating exactly where I'm going with this problem, so please stay to the end. But, so, what they do in Directive 15, though, is that they say that there should be two questions. The first question asks you your race, so that's where you would say your African descent, and then they ask you your ethnicity, and ethnicity means Hispanic versus not Hispanic, right? And that's the way that they try to deal with that problem, but it doesn't work. And the reason it's not working is that most Hispanics do not answer the race question, and what you get is missing on race and then Hispanic. And so what's happening as the Hispanic population increases is that the census data is now showing other as the fastest growing race group in America. So the problem is that we're trying to take human variation, which is inherently continuous, and we're trying to put it into categories. And that is the folly of race and the folly of ethnicity, frankly. So Directive 15 has been updated, and I'm going to skip ahead with those updates, but they were updated in 1997. And I will make these slides available so you can have them. But I did want to also show you this. These next, now I know in the next three charts, I'm breaking every rule of PowerPoint making. And I'm doing it intentionally because I don't necessarily intend for you to be able to read the chart. What I'm going to show you is the way that race was measured on every census in the history of the country, beginning in 1790 and ending in 2010. And I want to show you, so in the first year, 1790, was the first census, it was free white males, free white females, all other free persons and slaves. In 1800, they add Indians. Down here, we start adding free colored persons. Here is where we get mulatto in 1850, and then Indian gets added back in here. Here's what we start doing with what they do in Brazil, quadroons, octoroons, and now we get nationalities added here, Chinese, Japanese. As we move forward into the next century, See, where does it start? Here we have religions getting added now, Hindu. Blacks become Negroes in 1930. Notice now, as we move into the second half of the 20th century, I start to need more lines to get all these categories in, right? Right? It's starting to really get good. Now we have part Hawaiian in here. So just being part Hawaiian is enough to get a category. But we don't do that in 70. And then by the time, and down in 2000 and 2010, as you see, I now lead 1, 2, 3, 4, 5 lines to get all the categories in because everyone has now successfully argued to have their own box on this census. And this is, so now when you look at trend data showing something about race, we need to consider that the way the variable is being measured is changing, who falls into what category changes, right? And this is a lot of what our science is based on, right? So hopefully some of you see the challenge of this. The next problem that I want to describe is confounding with socioeconomic status. Now, clearly, there's a correlation between race and ethnicity and socioeconomic status in this country. The racial and ethnic minorities are more likely to be of lower income status, right? So what happens is sometimes we think that, therefore, if you are a member of racial ethnic minority group, you are therefore poor. Now, the way that we try to deal with this is through we don't typically in the social sciences and in epidemiology, we generally don't try to deal with this problem through research design. We try to deal with it through our data analysis. Now, this problem of confounding is a problem in all sciences, and we have to find creative ways to solve that problem. Typically, in the laboratory sciences or when you're doing experiments, you're able to deal with this confounding problem by sample selection, by your research design. You're able to exclude certain groups. You're able to do it in ways that you take some of these conflicting problems out of the equation. Typically, in the social sciences and in epidemiology, we don't do it that way. What we want usually are large, national representative samples, and we try to deal with this problem through data analysis, through a technique called multivariate modeling. So how many of you here are familiar with that term? What, are you afraid? I mean, I know that's not true. I know Marino's doing a better job. Huh? So multivariate modeling. So for those of you who are adherents to multivariate modeling as a solution to confounding between race and socioeconomic status, I'm going to do a little experiment for you, a little demonstration that I think illustrates the problem of using multivariate modeling to solve this problem of confounding. So this demonstration, I'm going to use the 2002 National Health Interview Survey. So I think we would all admit this is the official record of the health of the US population, the National Health Interview Survey. It is the largest data set. It is literally the official record. I'm going to use the 33,000 cases, that is adults over age 40, in that sample, right? So this is a big sample, and so I'm not trying to game the system here. And I'm going to do a very simple analysis. I'm going to look at whether or not there is a difference between black and white people in having a disability. And I'm measuring disability, also setting the bar very low. I'm going to use having one ADL. An ADL means activity of daily living, which is a measure of disability. So can someone confirm for me that I have set the bar low? One ADL. Is anybody out there? Can I get a witness? Anybody? There we go. That's good. Raise your hand loud and proud. Right. Right. Okay. So I set the bar pretty low. And I'm going to do a simple analysis. Is there a race difference in ADL limitation controlling for income? Now, so what do we do? So a Biostats 101 class would tell us that the first thing we do is we look to see, is there an association between race and having one ADL limitation? So we've done that, and what this tells us, this number right here, this statistic, 1.46, means that African Americans have 46% greater odds of having an ADL limitation. And this confidence interval does not include 1, so it says that this is a statistically significant finding. Am I right? Right? So I'm passing Biostats 101 so far, right? Good. All right, now we move on. The next thing we want to do is look at income and ADL. So as income increases, the odds of having an ADL limitation is decreasing, right? And the confidence interval says what? Come on, I don't hear you. Thank you, there you go. So far everything is as we expect, right? So what do we do next? So for Biostat 102, we put race and income together and see what happens. Here's what we do. And what happens, first let's talk about income. So the income relationship is the same, right? It hasn't changed. As income increases, the odds of ADL limitation decreases, and these are again statistically significant, so that's right. But what happened to the race effect? It is no longer statistically significant. So what do we do next? Anybody? Nobody's brave enough. We write the paper up, we publish it, and we get a promotion and a raise, right? That's what you do. I mean, what am I, alone here? I mean, right? That's what you do. And then the dean is happy, and you get the merit raise, and all is good with the world, except that we have now added false information to the research literature, because if we took this step, and we simply arrayed the data by race and income, and looked within each cell, we would see a couple of interesting things. What just happened? Okay, we would see that in the lowest income group of less than $20,000, there is in fact a statistically significant difference. This difference is significant. And more importantly, we would see that in the highest income group, over $75,000, that there are only 8 events here. So what this means is that in the National Health Interview Survey, the largest, most official data set we have, there are only 8 African Americans in that entire data set who have an income over $75,000 and have at least one ADL limitation. So how confident do you feel about calculating a rate on the basis of 8 events? Okay, now, this analysis that I did here would be what we would call underspecified. I would never be able to publish this article in reality because I'm leaving out way too many other variables. But every technique, every analytic technique that has been known that I'm aware of would require an even larger data set, right? Because the more variables you add, the larger your sample needs to be. So even in this simple analysis, we can't do this simple analysis with the National Health Interview Survey. So my question is, how many articles have you seen, and in some cases have you yourself written, where you've done much more complicated analysis with smaller samples and don't know whether we even have this type of problem? This is eventitis, the disease of having not enough events to calculate simple statistics. Now, I know some of you may be getting depressed, but don't be depressed, because if you go to PubMed, you put my name in, you will find that I have committed some of the very same sins that I'm here talking about today. So the point is not that he who is without sin should cast the first stone, but rather we should repent, go forward, and sin no more, now that you've been enlightened, right? That's the point. No more sinning. Right, that's the point. We've all sinned, I have too. I have committed some of these same sins. So, now if you see me publish something after today committing the sins, now you can say something about me. Another problem we have is this. So this is a high school in the Baltimore metropolitan area. As you see, I'm driving onto the campus here. We see the buildings off in the distance. You can't see the buildings from the entrance, by the way, because it's too big. I come around to the side of the campus, and here's the gymnasium where the basketball team plays at this high school in the Baltimore area. Here's another high school in the Baltimore area. This one is in the upper middle class suburb. I'm at the entrance again. As you can see, there's a lawn and there's some trees, but the building is clearly visible from the street. Come around to the back of the building. Here's the soccer team going out for afternoon practice on a wide open field. No bleachers for the spectators to watch the baseball game. And here are the portable classrooms in this upper middle class Baltimore area high school, right? Now, Here's another high school. This is in the Baltimore area as well. There's no lawn, but we've got some weeds here in the cracks, and we've got a tree. And so what is my point? The point is that when we code in our data sets, high school graduate, and we treat all high school graduates as if they're equivalent, we don't account for the fact that there may be qualitative differences in the life chances and opportunities of the students who go to these different schools. What is your guess? Do you think that there are race differences in who goes to which of these schools? What's your guess? You're right. Do you think that there are socioeconomic status differences in who gets to go to which school? Yes. Do you think that there are differences in what proportion of their graduates go to college? Do you think that there are truly meaningful differences between the graduates of these institutions? So can we logically code them all in our data set as high school graduate and treat them equivalently? Well, then why do we do it all the time? Including me, don't worry, it's okay. I've done it. I've sinned before I reached enlightenment. So it's all right. Just come be baptized in understanding the new ways, the problems, the complications of doing this research. The next complication I want to talk about is segregation. So the United States is a dramatically racially segregated country. And this has implications for health disparities research. Here's an example. So there's this statistic called the IOD. It is the Index of Dissimilarity, is what it stands for. And the way you read this statistic is that it ranges from 0 to 1. The higher the number, the closest to 1, the more segregated the city is, okay? So a score of 1 means a perfectly segregated city, means that there is no neighborhood where people of different racial ethnic groups live together. A score of 0 means complete integration. Every single neighborhood is fully integrated, right? So everything is in between tells you the relative level of integration. Here's Los Angeles at 0.66. So that means 66% segregated. 66% of blacks in Los Angeles would need to move to another neighborhood to make LA racially integrated. 63% of Latinos would need to move to another neighborhood to make LA integrated, right? So that's how you read that statistic. Here's my hometown, New York, 81% segregated for blacks. And here's Detroit, 84%, right? And at the bottom here, I have the average for the 25 largest cities. So the average city is 64% segregated for African Americans and 49% segregated for Latinos and 41% segregated for Asians. We did a report where we looked at all of the cities. This is every city of 100,000 people or more. So we're talking more than 500 cities around the country. And we did this distribution to show segregation and across the cities. The blue line shows 2010 census. As you can see, we have the typical bell curve with the mean segregation for blacks being at about 61. Here's a similar chart for Hispanics. Again, the blue line is for 2010. Bell curve again, mean for Hispanics is right at about 48, right? So we've got a very segregated country. So what does that mean? That means that we have differences by race and ethnicity in who is getting exposed to environmental risks. We have differences in who has access to healthy neighborhoods. We have differences in who has access to good quality health care. But then we take the national statistics, we don't account for the fact that people are segregated and living in different environments and have different exposures. And we look at the statistics and we see difference and we say, well, there's a difference here, so that difference must be explained by something about the biology of race. Which in the beginning of the talk, I just showed you something about the biology of race, right? See, now this is the way that we typically think about health disparities in these very simplistic terms, but in reality, it's extremely complicated because we have to account for all of this. Here's an example of what I mean when I talk about segregation. So this is a corner store. These stores are ubiquitous in northeast and north central cities in this country. They sell pretty much cheap wine, beer, malt liquor, cigarettes, and lottery tickets. Maybe a little bit of food. Not really edible food, but some food. This store, by the way, this one is a couple of blocks from my office. You walk into this door here, and it's a room about, 10 by 8, encased in plexiglass. You can't touch any of the merchandise, right? You go up to the counter, and you speak through the glass, through the holes in the glass, to the clerk who's on the other side. You look through the glass in the refrigerators in the background that have glass doors on them. And then you tell the clerk what type of malt liquor you want. You put the money in the turnstile, they turn it, take the money, put the malt liquor in, turn it back. This is as impersonal a transaction as you can possibly have in a retail setting. The only thing more impersonal would be a vending machine. But these stores are everywhere. This is my favorite store, by the way. When I'm taking this picture, this is one of those special moments. I'm actually standing in the parking lot of a funeral home, and there's a funeral going on of a 22-year-old black male that just had a heart attack and died. And I'm taking this picture of this store directly across the street, and the store has this sign that I did not Photoshop. I just blew it up for you to see it. L&M Liquors. They sell beer, wine, and medicine. And and I really appreciate the truth in advertising because they do sell beer, wine, and medicine. And of course, the medicine that they sell is the elixir for the ills of poverty, malt liquor, which has about double the alcohol content as beer, by the way. So we did a study to look at the location of these stores in Baltimore to see, are these stores located in different types of neighborhoods, and what are the characteristics of these stores? So we got the liquor licenses, we put them into their census tracts, and what we found was that they were almost exclusively located in low-income, segregated African-American communities. This is part of the infrastructure of communities that produces the disparities that we see in our statistics. But if we don't account for the fact that not everyone is living in neighborhoods with corner stores, and we only look at national statistics, then we can be fooled into thinking that maybe there's some gene that makes you a certain racial or ethnic group, and that gene also causes you to have cancer and heart disease and strokes and hypertension and diabetes and schizophrenia and HIV and homicide and play basketball and dance and all the other stereotypes, right? So when you think about it, how utterly ridiculous that idea is. But sometimes this idea of there being true biological difference between race groups kind of creeps into our thinking in very subtle ways. The next problem I want to talk to you about is reporting the data for health disparities. And this one is quick, but this is a real issue here. So what I've done here is I've plotted across time the disparity in infant mortality by race from 1950 to 2004. And I've plotted here this red line, which is the ratio of the two. And if you look at the ratio, what this is telling you is what? That the disparity is getting worse, right? But here's the problem that we have to be careful with doing this type of analysis because it can be misleading. I'm going to show you a quick example. These are made-up numbers, okay? So this is some made-up disease, and we're going to look at a change between 1960 and 2005 in that disease, right? These are not real statistics, right? So let's say this is the trend for blacks. It went from 150 cases per 1,000 people down to 60, right? And it dropped by 10 cases every 5 years, 10 fewer cases. You following me? You out there? Yes. Okay, there you go. Yeah, I like that. That was good. Now, here's the same analysis for whites. So as you can see, in the beginning, we had this difference here of 50 cases, and each year, the whites also went down 10 cases every 5 years, right? If we calculate the difference between blacks and whites, we see that every year, since both groups are going down by 10 cases, it's still 50 case difference, right? So that you would conclude what? That the disparity has not changed. But if you did it as a ratio, this is what happens. We see that the ratio is increasing, and then when we get to 2005, we say, wow, we've gone from only 1.5 or 50% higher rate in 1960, and now we have 6 times the rate. Is that accurate? So we have to be very careful when we present data that we present this data in a way that it doesn't mislead. And when you see people plotting ratios like that, which you often see, you will often see that, be very careful in how that's being interpreted, because you could, each statistic is telling us something that's important. And so don't get me wrong, the ratio is not an unimportant number. It's meaningful, but its true meaning and its ability to mislead is great. And it's only valuable in the context of also understanding what's happening with the difference. So that's all I want to say like that. Now here's my last point, and this gets to your question about the Afro-Latinos. Right, now, so I've already told you that my family's from the Dominican Republic, so I'm an Afro-Latino also. As I say, a Black-tino, I like that, Black-tino. I think that's kind of cool. It's just me, but it's just my thing. You don't have to use it, but I think it's cool. So I always wanted to do this study on Afro-Latinos. I always wanted to know, are Afro-Latinos more like African Americans in their health patterns, or are they more like other Latinos in their health patterns, right? So the title of the paper is, Are Black Hispanics Black or Hispanic? Is the title of the paper. And it took me, I've been wanting to write this paper for probably 10 or 15 years. I've been trying to write this paper. And I haven't been able to write the paper. And the reason that I haven't been able to write the paper is because of what I said earlier. Black Latinos are not answering Black and Latino in the data. So we can't find Black Latinos, and they're hidden. And so we had to wait until we can get enough years together to combine enough people to get enough Black Latinos to be able to say anything about that population. So we used the National Health Interview Survey. We had to combine 10 years of data. And this is the point I want to make to you, that sometimes if you want to study subgroups, because some of the most interesting information comes not from using those broad 5 categories from Directive 15, but by getting underneath those categories and finding out what's happening within those categories, because there's so much diversity within those categories. But sometimes you have to get creative to find ways to get access to that data. So we had to combine 7 years of data from National Health Interview, actually it's 8 years, National Health Interview Survey, to be able to do that. And what we did basically was we did a set of analysis where we looked at different health outcomes, health behavior outcomes, and health services utilization outcomes, and we compared the confidence intervals between Black Latinos with Black non-Latinos and Latinos that are not Black, to see who are they more like statistically. Are they more like, which group are they most like, right? So here are just kind of the results. We looked, we looked at these health services being uninsured, having a usual source of care, had they been seen by a doctor in the last 12 months. We looked at health status, hypertension, heart disease, diabetes, asthma, self-rating of poor or fair health, and then we looked at health behaviors like smoking and obesity. So first for health status, what we found when we look across these is that actually we find aspects of both for most of the conditions, but when it comes to hypertension, they were most like Hispanic, non-Black Hispanics, and they were in the third category. So we know that there's an extremely high rate of asthma among the Hispanic population, but if you disentangle that by nationality, you find that it's really the Puerto Ricans, where you have an extremely high rate that's really driving that rate. And of course, a larger proportion of the Black Latinos were from Puerto Rico. And that came through here as being one of the areas where their Black Hispanics were like neither group because they were much higher than both groups in asthma. For health services utilization, they were more like Black Americans in terms of their use of health services and their access and availability of health services. And finally, for health behaviors, they were more likely to be like Hispanics. And my hypothesis about that is that probably it's because health behavior is more tied to culture. And culturally, you would expect that they would behave more like other Hispanics, not like Black Americans. And that's probably what's going on. So this is the summary of the results. So these were the 5 topic areas that I wanted to discuss with you, things that I think you need to be aware of and be conscious of as you go forward in doing your research in health disparities. So I guess I'll stop for any questions at that point.
Okay, questions? One question over there.
Okay, so now everything's gonna be big data, and we're looking particularly at hospital and health information. We're now teaching our students to look at all this big data. So, I hear you saying that there are flaws in this big data, and as we look at it and make decisions, and this information is supposed to help us support our decisions, that maybe we're making wrong decisions and coming to wrong conclusions.
Yeah. Well, there's always that risk. Now, I do embrace this move towards data-driven policy and data-driven, performance. I think it's important. And yeah, the data has flaws, but I think operating in an absence of data is even more dangerous. Operating only based on experience is. So we were just talking about this before I came up. So if you're in the clinical setting, all you see is who comes through the door, right? So you may have the perception that, there's a big spike in this condition because people are coming to you, and you now see that. You have the numerator, but you don't know the denominator. So you have no idea whether this is really representing a spike or a trend, or if people are just deciding to come see you as opposed to other clinics, right? And so I think the data is important. The data is not perfect. We need to find ways to do a better job in collecting that data. We need more nuance in that data. Human variation is inherently continuous, not categorical, but we're stuck with these categories. So that maybe we use the 5 categories, but then within those 5 categories, we create smaller categories so that we can look at smaller, more discrete groups and better represent subpopulations. So I think there's potential there still in this move to big data, and I don't think all is lost. I'm not pessimistic about it at all.
A question? Yes?
Very interesting. I'm a visitor, but very interesting. I want to put also the other side of the story. When our government went ahead with the ACA, they used big data. They did all the assessment and all the regulation based on big data. But when you go across the country, now the problem is that big data doesn't work in every community, especially socioeconomic. In order to give the subsidies and all these issues, it's completely inaccurate in different parts of the country. We come from Palo Alto, it's completely inaccurate in all that area. So I think there has to be a balance. You need to be very knowledgeable with big data, know how to use it. But you have to know your local data.
Oh, absolutely. Yeah.
You have to be able to communicate that to legislators to know that they're going to be variables throughout the country.
Exactly. You're right. I mean, I think if I could, I think you're right. What we need to do is we need to become more sophisticated. So it's not. I think we should embrace the move to data because I think there is potential to do better. I think that minorities do worse in the absence of data, right? So even flawed data is better than nothing. We need to get the data, and we need to be nuanced, and we need to be sophisticated in how we collect and utilize that data. And one of my points, I didn't get into it much today. I'll talk more later on, but you can't always use national data to talk about what's happening at the local level because this country is so diverse in so many ways. We span, 7 time zones? I mean, this is a huge country, right? And so I'm agreeing with you, but I think we need to be more sophisticated, not that we shouldn't embrace the big data move. We should just be more sophisticated in how we use it.
Big data is complementary with local data.
Yes.
That's what we need to know more.
No, well, I think local data is big data too. We need to be mining that data, but we need to be collecting our local data in a way that makes sense for our local area so that we can really understand what's happening in the service area that we're providing care for. But that's a big data approach as well. But that's part of what I mean when I say we need to become more sophisticated and more nuanced and make sure that we're understanding, the unique characteristics of our communities.
Are there any efforts by the United States Census to add to your long list of slides to combine the 2 ethnicity and race categories?
Yeah, there is.
And secondly, even if we were nuanced, we lose the ability to do national comparison because you according to an answer, they only have the categories that are official categories, race, ethnicity.
Yeah.
So it's very difficult to actually then make the judgments to go back and do the national comparison.
So what I would say is that, so first of all, the census, there is a move right now, and it may happen by the next census, to eliminate the two questions of the census and ask it as one question. And I'm one of the people who is fighting against that. If that happens, then Black Latinos disappear, right? There's no way to answer that question, right? We don't exist anymore because now they're going to all just say Hispanic, right? Or they're going to all say Black, but most of them are going to say Hispanic, and they're going to just disappear. So I like the two questions. It took me 7 years to get enough data to do a paper, but I'd rather wait 7 years to do that paper and have that data.
But one could combine it such that you would have Black, African American, Black Latino, White Latino, or other Latino. So you could actually combine them and have it all in one question, but people make a choice in how they identify both ethnically and racially. It's a complicated question. Even you may identify as Black racially, but very strongly feel that culturally you're Hispanic, you're Hispanic. So I think people need to be given kind of that choice.
Yeah, but that's not what their proposal is. The proposal is to just add Hispanic to the other 5 categories, and that's what they're looking at doing. So I think something that is more nuanced, I'm always for that. So but this issue of being able to aggregate up, I think even that example you just gave does allow you to aggregate up to the national level, because if you had Black Latino, Black non-Latino, Black Caribbean, Black, whatever, you could simply combine those categories and go back to the original Black category. So at the local level, if I'm running a hospital or a health system in a local geographic area, and I have, for example, a large Sudanese population, I'm going to want to have a variable in my data that collects data for the Sudanese population specifically, because I want to know about that group. And then I may even want to know about religious differences within that group, because I need to know if my treatment patterns are affecting one group or the other differently. And that's what I mean when I say more nuanced at the local level. But there's no reason why you still couldn't aggregate that data up to the national categories for reporting at the national level. So we need both. And you better pick her. You kidding me? You want to go home?
Yes. Well, I will go to something you mentioned at the beginning regarding conversation with the scientist, and she was so excited about. That could be me. I mean, I'm working on something that the gene is fascinated by the genetic component. What kind of forum on good national level with disability do you think would be possible that we can come together and bring that discussion? Because these students here are associated with a lot of different problems that we think are very critical in the area of science, because we think they're going to impact the disparities and the purposes. We want the community to take it to the next level. But then we have the other side of the next we're talking about, where you're a social scientist and I'm a biological scientist, and it seems like we have different languages when we're talking about that. What would you recommend, kind of a special meeting forum to discuss that? Because there's a sense that biology only going to be with biologists and social science is going to be with social science. But we're working in a group where humans are responding to the environment, whether it's stress or abuse, and that is affecting our body. And that is a biological change because of that other thing. They say it's not the genetic code, it's the seed code, but how about the seed code of the genetic code? Where can we go and discuss that?
Yeah. So for those of you that couldn't hear, the question was, that we have the biological. So to use the most crude designation, we're the biological sciences and the social sciences, and there's no place really for people to have those cross discussions. The national conferences are either one or the other. The academic departments are one or the other. And so the Broadway Johnson Foundation tried to tackle this problem. I was actually on the advisory committee for this, where we created a postdoc program called the Health and Society Scholars Program. And the idea was that we would take PhDs from the social science and train them in biological sciences. We take PhDs from the biological sciences and train them in the social sciences. And then what happened is after they finish the postdoc, we now have these people who have this training, but there's no place to go. There's no department, there's no university, there's no job. So what happened is that the social scientists all went back to social science, the biological science all went back to biological science, and we lost all of that investment in those people. But there are people, a lot of people, who are of this mindset that we need to solve this problem, because any really important problem requires multiple disciplines, right? Anything that's really substantial is going to require this. So I think there are ways you can do this. So first of all, there are conference grants. You could create a conference grant on integration of the social and biological sciences to start to create visibility. You could publish on the topic, publishing in both social science and biological science journals. You could, and I know that's not easy to do, but I think you can get those published in certain locations. For example, American Journal of Public Health would probably take something like that. You can write an essay for the Institute of Medicine on the topic. You know, I can help you with that if that's what you wanted to do. I think there are ways you can start to, but right now we're at a stage where I think we still have to break through the barriers, and those barriers still exist. And I do think that at NIH that there's more openness to that in the study sections. I don't know, am I wrong? I believe there's more openness to it. Some.
I'm not sure.
Well, I think it needs to happen, and I think that we just need to keep pushing that until we get that breakthrough. There are some departments, like Penn State has a department of, I can't remember the name now, but they have a department that's supposed to be doing that work. I mean, there's some traction happening somewhere, but it's still very early.
And that's why one of the things we're trying to do at the center, with that, having the crosstalk. Yeah.
You spoke about raw data being kept better than no data. And my question was, how do you feel about when that negatively affects large ethnic groups? For example, we have the United States current classic campus screen recommendations that have been, where they've raised the age to get the kids accepted.
Yep.
It's based off of studies that involve over 100,000 men, but less than 5,000 of any African descent at all. So obviously, I would consider this flawed data, and then it's affecting the men that are dying the most in that disease. So how do you feel about that?
See, I'm very familiar with this issue. I would say that it's not flawed data. It's flawed. That was flawed interpretation of the data, right? That was the data itself wasn't the problem. Had they isolated that 5% and looked at what was happening with them, then I think they might have seen something different. And they made recommendations based on men at average risk, and silent about men at elevated risk and what they should do. So I think that what they did was they made an unsophisticated interpretation of that data, which led them to a decision that I think is a bad decision. The data was the data, and they didn't use the data in its most effective way. And I think that is what led to what I consider an unfortunate decision. I was thinking a plane was getting ready to hit. I was like, what is happening? I was trying to figure out which direction to run. You know.
So some of these studies are now incorporating these genetic markers of ancestry to study health disparities.
Yeah.
Of course, they don't consider environment, socioeconomics. What do you think is the role of using these markers of genetic ancestry? What do you think is going to be the role in health disparities research?
I don't like it at all. I'm really worried about it, about what they're doing. This is another one of my former roles on an advisory committee for the National Human Genome Institute, where they were going into Africa to collect samples that they were going to use as their base samples to say what your ancestry was. And what I kept saying was, but wait a minute, you're going into Africa in the 20th century and you're going to collect samples of people currently living in these countries without, I mean, we don't, what about accounting for migration? That people came in from other parts of the world, and people, had, children with other people from other parts of the world, and that the gene pool is not a pure gene pool. You can't say that this gene comes from this country. And they said, thank you very much. And they flew over to Africa and they got the samples. So I'm real skeptical about whether or not there's a gene that belongs to a specific group. And I'm open to being convinced that you can do that, but I'm not currently convinced, but maybe one of you will be able to convince me that you can isolate an Igbo gene and say, this is the Igbo gene, and if you have this, you are Igbo. But what happens, what I've seen, is that you find the Igbo gene, because there's a high prevalence of that gene in Igbos today, not 1,000 years ago, and then we look at other populations and we find that gene is in the other populations too, just not at the same frequency. And that's what we're really talking about. We're talking about prevalence of different genes being higher or lower. So I'm not crazy about it. I don't think it really gets us anywhere, because I think that race really is fundamentally social. It's how people treat each other. It's how people experience the world. And then that then affects you physiologically. To me, that's the story that I find most fascinating about this.
We used your textbook here in the Health Disparities.
Thank you.
Campus.
Thank you.
And enjoy it. But you've mentioned that you're ready for a new edition. What are some areas that you are looking at?
Yeah. So what I want to do is talk to people like you who've used the book and find out what's missing. So I did that book. This is a textbook on minority health. I wrote that book because I was teaching a class and there was no book. And then I would just complain about it. And I found myself at a conference once talking to people who teach courses at their universities, and we're all complaining that there's no textbook. And it occurred to me, like, well, if there was, who would write the textbook? One of us, right? So why don't we need the book? And if we want to create an infrastructure that makes minority health and health disparities a part of the curriculums of all health sciences, we need to create the infrastructure for that. And having a textbook is an important part of the infrastructure. So I decided foolishly to write that textbook because I had no idea what it meant to write a textbook and just how much work was involved. But I did get it finished, and it's time to be updated. So I would turn the question back on you and say, I'd like to know, how it's being used and what topics that are not covered should be included in the next edition.
Thomas, okay, one more question.
So have there been any studies to assess the impact of how segregated the city is on the status of the various race movements?
Oh yeah, there's been a number of studies on that. A number of papers have been written on that topic. I can share with you some references if you like, or maybe I can send them back and you can share them with everyone. But there's a pretty decent literature, probably 25, 30 papers or so on that topic, all showing that segregation is associated with worse health outcomes.
You mentioned this issue of health disparity. What are the arguments that you have heard about some people that believe that disparities don't exist?
Yeah.
And what do you think how we can address those issues?
Yeah. So I would say that I used to hear that a lot. I don't hear it as often as I used to. People, the disparities deniers, I don't really hear them as often. But when I did hear that a lot, my solution was always the data. I would simply say, you pick your data set and let's look at it, and you're going to find disparities, and you're going to see consistency, and you're going to see this consistency across chronic conditions, infectious diseases, injuries and accidents. I mean, you name it, disease category, the disparities are there. So that's been my solution, is kind of to use the data to say, you can say you don't want to address disparities, but you can't say they don't exist because the statistics are so overwhelming.
Now, you were one of the first person to analyze disparities in what you say equalizing socioeconomic forces.
Yeah.
And you published a couple of papers on that. What are your main findings on that in understanding the causes of disparity?
Yeah. So what you're talking about is the study I'm going to talk about tonight, which is called the edict study. What we did to deal with this segregation problem is that we went around to find communities that were racially integrated, and then we replicated the National Health Interview Survey protocol. And we wanted to say, do we find the same disparities when people are living in the same social conditions? And what we find is that the disparities are either much smaller or we find no disparity. So for example, we published one paper showing no race differences, and this was black-white differences, no race difference in obesity among women. Now, nationally, African-American women are about 87% more likely to be obese compared to white women. But in this community where they're living under similar conditions, we find no disparity in obesity. We find no disparity in diabetes. Nationally, it's about 61% greater odds of being diabetic. In our sample, we find no significant race difference in diabetes, rates of diabetes. Hypertension, we do still find a difference, but that difference is a lot smaller in that community. So that the conclusion there is that when people live under similar social conditions, they're more likely to have similar outcomes, and that we have to account for the fact that people of different groups live in different environments when we look at these national statistics. And then once we do that, we're able to isolate those social determinants. Now we can look at, for example, what is it about hypertension, why we still find a disparity among people living in the same environment. And now we can start looking at what are the physiological, what are the biological factors that might be producing this difference in hypertension, for example. So the idea was to try to do what you guys in the biological sciences are able to do typically, which is to control for confounding factors through your design. So you're studying human beings, you can't put them in a lab and control how much humidity and control how much light and control, you can't do that. I guess you could theoretically, but the IRB might not allow you to do that. But so we can't do that the way you can do with rat studies. But so the best we could do is try to find a naturally occurring environment that controls as much of that as possible to say, can we isolate how much of this disparity is being produced by the social conditions and how much is being produced by other things. And once we take the social conditions out, we see how much residual disparity is left. And then we say, okay, now let's understand what's happening biologically, what's happening behaviorally, what's happening, in the gene-environment interaction.
Well, thank you very much for coming. Thank you, Dr.
Thank you.